Welcome! This short video series is intended to assist you, the bedside clinician, in providing safe and effective care to your patients with Shiley tracheostomy devices. This video series includes 4 topics: skin and stoma care, cuff management, suctioning, and device cleaning and care. We will review evidence-based practice and information that can be found in the Shiley Tracheostomy Instructions for Use, or IFUs. As always, this should be a guide to general tracheostomy care. Hospital facility policies, guidelines, and manufacturer instructions should always be referred to and followed. To prevent skin breakdown and irritations, it is important to provide proper stoma care and keep these areas clean and dry. External forces, such as the tracheostomy device or weight of the ventilation equipment, friction from manipulation of the device during care, or presence of secretions or moisture may contribute to complications. Patient characteristics such as anatomy, perfusion, and nutrition can also increase risk of breakdown. A soft flange that can decrease surface contact and/or promote airflow to the skin through windows may decrease risk of skin breakdown. Routine skin and stoma visual assessment should be performed, including the skin areas under the trach ties and behind the neck. Also ensure the patient is in a neutral neck position and prevent the weight of the ventilator equipment pulling on the tracheostomy tube. Devices with a transparent flange may facilitate assessment under the flange and may minimize the need for manual manipulation. When cleaning the skin and stoma area, remember to keep the trach secured. This can be achieved by keeping the tracheostomy ties in place or using a buddy system to hold the trach in place during care. This may decrease the risk of accidental decannulation. Cleaning of the stoma and skin area can be achieved by using cotton-tipped applicators or gauze soaked in normal saline or a solution of half-strength hydrogen peroxide to remove moist or dried secretions from the area. Dry the area with gauze to remove excess moisture. Secretions on the flange can also be removed with normal saline-soaked gauze. Replace soiled dressings with pre-cut or folded gauze to create a windowed site around the stoma. Don't forget, if excess secretions are present around the site, suctioning may also be warranted. As previously discussed, weight from the ventilation circuit or excessive patient movement can result in accidental decannulation. Patient factors such as obesity, agitation, swelling of the neck, or excessive coughing can also increase risk of accidental decannulation. Ensuring neutral positioning of the neck, preventing pulling from the ventilator circuit, and maintaining trach ties with only 1 finger depth may minimize this risk. Being prepared for an accidental decannulation is critical, as quick action is needed. A replacement trach of the same size and 1 size smaller should be kept at the patient's bedside and reinserted in the event of decannulation. If reinsertion cannot be achieved, mask ventilation is needed until oral intubation can occur. Cuffed devices provide lung protection against aspiration and help maintain desired ventilatory settings. Although cuffed tracheostomy tubes offer many advantages, cuffs may also create complications if correct cuff pressure is not maintained. Tracheostomy cuffs inflated too high can quickly decrease tracheal perfusion, potentially causing injury and ulcers within the trachea's mucosal lining. Tracheostomy cuff pressures that are too low can increase risk of aspiration and increase the potential for respiratory infection. With perfusion critical to the health of the tracheal tissue, cuff pressure should be checked regularly to ensure a pressure between 20 to 30 centimeters of water per the device IFU. Automatic cuff pressure monitoring devices may also be used to perform this function. Many factors may impact cuff pressure, including position changes. Measuring cuff pressure may be a shared function between nursing and respiratory therapy. Make sure to check with your facility policies to identify responsibility and ensure the pressures are being monitored. There are 3 types of suctioning that can be performed: oral, tracheal, and subglottic. The patient condition will determine which areas need to be suctioned routinely. Oral suctioning, using a handheld suction catheter, is necessary for those who cannot swallow or who have difficulty swallowing. Tracheal suctioning, through the tracheostomy tube, maintains patency and prevents secretion buildup. Subglottic suctioning will be reviewed in more detail later in this video. Suctioning should be based on patient assessment, but may be placed on a routine schedule of at least every 8 to 12 hours. Frequent patient assessment is critical for the patient with an artificial airway. Indicators that a patient is in need of suctioning can include excess secretions at the trach site, coughing, low oxygen saturation levels, patient agitation, or confusion. Coarse rhonchi over the trachea has been shown to be the most sensitive indicator for needed tracheal suctioning. Tracheal suctioning can be achieved through open or closed suctioning methods. Although the equipment differs, the suctioning procedure is similar. Suction regulator pressure should be set while occluding the suction catheter by crimping the suction tubing or occluding the end of the tube. Typical suction range is -80 to -120 millimeters of mercury and should not exceed -150 millimeters of mercury. Before performing suctioning, remove the inner cannula. If the patient is on a ventilator, pre-oxygenate the patient either manually with 4 to 5 breaths of 100% oxygen via a bag valve mask, or 100% O2 setting on the mechanical ventilator for 2 minutes. Insert the suction catheter into the tracheostomy cannula just deep enough to retrieve secretions. Deep suctioning is associated with more adverse events and has not been shown to be more effective. Release suction pressure and withdraw in a slow, circling motion. Suction should only be applied when withdrawing the catheter. One full cycle should not last more than 15 seconds and can be repeated as needed. Allow the patient to recover between suction procedures. If the patient uses a fenestrated tracheostomy tube, be sure to replace the inner cannula with a non-fenestrated inner cannula before suctioning to prevent the suction catheter from protruding through the fenestrated slots and potentially injuring the tracheal mucosa. Open suctioning should be done using aseptic technique. A catheter of less than half the size of the inner diameter of the tracheostomy should be used. The inner cannula dimensions can usually be found on the flange. Sterile normal saline can be used to clear secretions in the catheter between suction passes if desired, but is not necessary. Open suction catheters should never be reused, and normal saline installation into the airway to facilitate suctioning should be avoided. Closed suctioning does not require aseptic technique, as the suction catheter is within a sleeve. Using the manufacturer's guidelines, unlock the suction catheter and ensure the suction is attached and working. Once suctioning is completed, make sure to lock the catheter per the device's instructions. Subglottic tracheostomy cannulas incorporate an integrated suction line designated by a yellow cap, allowing for the removal of secretions that pool above the cuff. This may help decrease aspiration that could lead to nosocomial infections, such as ventilator-associated pneumonia or VAP. Subglottic suctioning is different than traditional tracheal suctioning. Subglottic suctioning does not take place within the tracheostomy tube inner cannula. Therefore, there is no need to pre-oxygenate or use aseptic technique. And unlike tracheal suctioning, there is no lung decruitment. Thus, this suction can either be continuous or intermittent, as recommended by the device IFU. Connect the suction tubing to the suction regulator and check suction pressure by occluding or pinching the tube. Set the regulator to intermittent suction at -100 to 150 millimeters of mercury, or continuous low suction at -20 millimeters of mercury. Then connect the yellow port on the tracheostomy tube. There may be only a small amount of secretions, as these are only those that are pooled above the cuff. Once suction is complete, disconnect from the tracheostomy tube and close the yellow cap to protect integrated suction access. Cleaning or care of the inner cannula is primarily done to maintain device patency through the removal of accumulated secretions. In disposable inner cannula products, the inner cannula is used once, thrown away, and replaced with a new disposable inner cannula. A reusable inner cannula allows you to clean and replace with the same inner cannula. Manufacturer guidance for cleaning should be followed, but typically include either half-strength sterile normal saline and hydrogen peroxide, half-strength soap and water, or sterile normal saline. Soak the inner cannula in the solution to soften dried secretions. Then use a tracheal brush to physically remove debris. Rinse with sterile normal saline to remove debris and solution. Dry and replace. Trach ties should be replaced when soiled, and the flange can be wiped with saline-soaked gauze. Tracheostomies vary in material and design. It is important to follow manufacturer recommendations and facility policy for cleaning. Due to a lack of standard for cleaning frequency, cleaning should be based on patient need and facility policy. Patients with tracheostomies may have difficulty clearing secretions on their own. Though suctioning is the primary method of assisting with secretion management, other interventions can also be helpful. Humidification can help keep secretions thin and easier to remove. If humidification is used, make sure to manage condensation that accumulates in the ventilation tube by either using the reservoir or temporarily disconnecting, emptying, and reconnecting the ventilation tube. Mobility, when possible, must also be promoted through positioning and passive or active range of motion. Ensuring adequate hydration is also important. Advocate these interventions for the patient while following provider orders. Caring for a patient with a tracheostomy tube is a critical part of patient care. Always follow your institution's instructions for proper tracheostomy care.